Welcome to our pharmaceutical chemistry class. Today we are going to talk about thiazide-like diuretics. We will include general structure of kidney, mechanism of action of thiazide-like diuretics, clinical use of thiazide-like diuretics, examples of some drugs, comparison between thiazide and thiazide-like diuretics. Firstly, let's take a look at nephron structure. Nephron is the functional unit of the kidney. It is responsible of blood filtration and removal of wastes. Each kidney contains about 1 million nephrons. It consists of two main parts, the renal corpuscle and the renal tubule. Renal corpuscle is composed of the glomerulus, which is a network of capillaries, and the Bowman capsule. It is a cup-like structure that surrounds the glomerulus. The process starts in Bowman capsule, where filtration is done. Small substances like water, salts, and glucose pass through, while larger ones stay in the blood. The other part of nephron is the renal tubules. It is divided into three sections: the proximal convoluted tubule, loop of Henle, and distal convoluted tubule. The proximal convoluted tubule reabsorbs water and glucose back into the bloodstream. In the loop of Henle, water and salts are reabsorbed to concentrate urine. The distal convoluted tubule adjusts levels of sodium, potassium, and pH. Finally, the collecting duct collects the filtrate from multiple nephrons and fine-tunes water balance. Through this process, the nephron removes wastes and maintain balance. How does thiazide-like diuretics work? Firstly, more sodium stays in tubule, pulling water with it and increase urine output, so cause increased sodium and water excretion. Secondly, sodium retention in the tubule enhances exchange for potassium and hydrogen, causing their loss. There is another exciting action of them. Unlike loop diuretics, thiazide-like diuretics increase calcium reabsorption, which may help prevent kidney stones and osteoporosis. Over time, these drugs also reduce peripheral vascular resistance, contributing to their antihypertensive effect beyond just diuresis.
Now, let's talk about clinical uses of thiazide-like diuretics. The main use of thiazide-like diuretics is to reduce blood pressure by inhibition of sodium and water reabsorption. Then it reduces the incidence of edema, which can reduce the risk of heart failure. They also increase calcium reabsorption, which may be used to prevent osteoporosis. They have the ability to inhibit carbonic anhydrase enzyme, that will lead to reduction in catecholamine and thrombin-mediated platelet aggregation and vascular contractility, so this will decrease the incidence of stroke. Now let's discuss some drugs individually. This include chlorthalidone, indapamide, metolazone, and quinethazone. The first drug we will talk about is chlorthalidone. It is a benzophenone-like system. Its structure contains sulfonamide group, which is essential for activity due to its acidic value. Carbon number 2 in benzene ring must be substituted with electron withdrawing group as chloro group. Benzene ring which responsible for stability, and it enhances binding to target proteins. So chlorthalidone is a long-acting drug. So, when can we use it? Chlorthalidone mainly is used for treatment of hypertension. It's considered the first-line therapy for uncomplicated hypertension. It is also used for management of edema. It may show some side effects. As a diuretic, it decreases reabsorption of potassium and sodium, so lead to hypokalemia, which may lead muscle weakness, arrhythmia, and hyponatremia, leading to hypotension. Other many signs like hyperuricemia may appear. It should not be recommended for patients who are sensitive to sulfa drugs, as it contains sulfonamide moiety. Secondly, indapamide. It is a prototypic indolene diuretic, contains a polar chlorobenzamide moiety and a nonpolar lipophilic methylindolene group. It does not contain a thiazide ring. Only one sulfonamide group is present. It has long duration of action due to its extensive binding to carbonic anhydrase in the erythrocytes. Let's take a look for the structure-activity relationship. Sulfonamide group is essential for activity. Amide linkage increases binding affinity to the target transporter and enhances potency and duration of action. What about metabolism? Indapamide is extensively metabolized. Less than 7% of the dose is excreted in urine as unchanged compound. Studies of patients with renal impairment showed little or no accumulation of indapamide in blood. In vitro studies support aromatic hydroxylation as a metabolic route. In many cases, it has many different side effects: irregular heartbeat, severe stomach pain, feeling sick, and tenderness in stomach. These give signs of pancreatitis. It may also lead to high temperature, yellow eyes, or skin, which is signs of liver disease. Allergic reactions may be developed. Thirdly, metolazone. It is chemically considered a quinazolinone-based structure. Let's learn about its structure-activity relationship.
Firstly, the essential quinazolinone core that retains the ability to inhibit the sodium chloride symporter in the distal convoluted tubule leading to diuresis. Secondly, the sulfonamide group at position 7 that is also essential for diuretic activity. Finally, substitution by chloro group at position 6, methyl group at position 2, and phenyl ring. Increases lipophilicity, bioavailability, and receptor binding ability. Metolazone is primarily used to treat edema associated with congestive heart failure, kidney diseases, and hypertension. It remains effective even with reduced kidney function, unlike other thiazides, which become less effective below a 30 ml per minute glomerular filtration rate. It has also been found to exert number of associated adverse effects including hypersensitivity reactions, gastric irritation and nausea, electrolyte imbalances, such as decrease in sodium, potassium, magnesium, and elevated calcium and urea level. Finally, quinethazone. Let's firstly discuss structural activity relationship. It has a thiazide ring that is essential for diuretic activity, ethyl group in position 2 and benzene substituents modify potency and lipophilicity, so duration of action. Sulfonamide group is considered the key for inhibiting the sodium chloride symporter in renal tubules. Hydrogen bonding enhances interaction with kidney targets, boosting the diuretic effect. Now we will discuss the most important indications for use. Quinethazone is used in hypertension, because it lowers blood pressure by promoting sodium and water excretion, also used with edema through reducing fluid retention from heart, liver, or kidney. It is safely used with chronic kidney disease and heart failure. It helps manage fluid buildup and prevent complications. So why thiazide-like diuretics? Thiazide and thiazide-like diuretics have the same mechanism of action. Our class of interest has a longer elimination half-life compared with thiazide type 1. It has been shown to exert additional pharmacological effects, then differently affect cardiovascular risk. In the meta-analysis of blood pressure reduction, thiazide-like diuretics seem to further reduce systolic blood pressure and diastolic blood pressure. Meanwhile, in the study of side effects, the incidence of hypokalemia, hyponatremia, metabolic alkalosis, and changes in other biomarkers level showed that there is no statistical significant differences between the two groups of drugs. So, using thiazide-like diuretics is superior to thiazide-type diuretics in reducing blood pressure without increasing the incidence of these probable side effects. Now it's time to test what you have learned. Good luck. Here we have reached the end of our class. Thanks for your attention.